Right, I'm joined by my colleague, Mr. Andrew Kinshuk, who's a consultant laryngologist here at Luft. So we're going to do a local anaesthetic biopsy of a tongue-based tumour in the clinic today. So Andy, can you just run through the equipment that you're going to be using for this procedure?
Yeah, no problem. So we've got everything laid out. This is all I need to do biopsies of nasopharynx, base of tongue and larynx. So you can see not very much equipment really. Probably the key bits, just to point out, are you need an interventional scope, so nase endoscope with a channel. The one we're using today is this one by Scope, which is only 35 centimetres long, so it is shorter than say a bronch, but in theory you could use a bronchoscope as long as you've got biopsy forceps that are long enough. It is slightly larger than your typical nase endoscope, so this is 5.5 millimetres in diameter, so it is important that you anaesthetise and decongest the nose properly. It's got a working channel of 2 millimetres, and then we're using these disposable biopsy forceps, which are 1.8 millimetres in diameter, so they will pass down the channel without any problems. Decongest the nose, I'm just going to use some lidocaine and phenylephrine. I sometimes use some Instagel as well, just depends on how much lubrication you need and how much more anaesthetic you need. An alcohol just to clean the lens of the scope, some jelly there for lubrication, and then for other anaesthetic I use a bit of lidocaine. So I've got a 2% there. Ideally for larynx I would use 4%. This is the only one I can get hold of today, but this does work quite well. You need somewhere between 2 and 4 mils that you can drop down through the channel scope onto the larynx. Just remember there's quite a lot of dead space within the channel, so you would need to draw up about 5 mils and you'd lose a couple of mils of dead space there. And we have a histology pot. I will try and take between 2 and 4 samples if possible. Remember, it's only a 1.8 millimetre biopsy forceps, so you're going to need quite a few samples to make sure you get that positive histology and get the answer and prevent further samples needed to be taken. So you're going to start off by anaesthetising the nose and making sure you give plenty of time for decongestion. Spray on this side. And then while that works, I'm going to get everything else set out. So I'm going to open up my scope, my procedural scope. So you take off the sheath, and then it comes with a little attachment which is useful for using the suction down or being able to pass the anaesthetic. So make sure you keep that to one side. So this is the small adapter. I'm going to add it to the top of the scope. It just sits in here. And this allows you to put the biopsy forceps down as well as the syringe. It just makes it slightly easier. We have got suction on this side if we want it to. I don't think we'll need it today, but we might get it ready as well. So I'm going to draw up the lidocaine. So this, as I said, this is 2%. Ideally for a larynx, I would want it to be 4%, but as this is more base of tongue, this shouldn't be a problem. I'm going to draw up 5 mils because you lose quite a lot in the dead space of the scope, but we may only end up using 2 or 3 mils onto the base of tongue and larynx. Right. So you should be starting to feel a little bit numb now. So I'm going to use a little alcohol just on the end. And then some jelly on the scope itself. Remember, it is slightly larger than a normal nasoendoscope, about 5.5 millimeters. So we'll have a look in and see if the nose is decongested. Thank you. So we're going to look in both sides and see which is the better nostril that we're going to go down. Okay, this side looks good, and I'll just check the other side as well. Slight spur and deviation on the right side, so we'll go down the left nostril. So you can have a little look down. Nice slow breaths, just feel a little bit of pressure. So I have used Instagel before when the nose, the septum isn't straight and you need a little bit more anaesthetic. So just, I don't need it today, but something to bear in mind. I'm just going to have a look at the area today. I'm looking at the base of tongue. Just pop your tongue out for me all the way. That's fine, pop it in again. And you can see you get a good view of the larynx as well. Just say E and sniff in. So looking at vocal cord movements. And there's scarring here that's from previous treatment coming from the left tongue base to posterior pharyngeal wall. But that's the area we're going to be looking at today on the tongue base. Good. Okay. Not too sore? Okay. So we're going to put now some local anaesthetic onto the area. There's an ulceration at the tongue base here, and so you'll feel a little bit. It might make you cough. Good. And there's no problem with coughing. If someone coughs, that helps spread the local anaesthetic around the larynx. A little bit more as well. And nice big coughs. So we can take that. And that works very quickly. So we can get our biopsy forceps ready. So I'm just going to give this to you to hold. Thank you. So before you put your biopsy forceps down, just to double check you know how they're working, making sure that they're working correctly. So you lift it up, pull it away, and then tight. Okay. And I normally put a little bit of jelly just on there to help it move, and I open up my specimen pot, so that's all ready to go. So you need to keep the biopsy channel, the biopsy forceps closed as you advance it. And you do need to work together with your colleague. It is a two-person job, and they have to understand what area you're going to biopsy and making sure the patient is comfortable and not too sore. One of the issues that we found with this procedure scope is you often get clouding of the lens, and so sometimes you have to take the scope out and clean that. So we've got an area now that we can see, so in a second I'm going to advance it into this area, close, pull back sharply. And we put that into the specimen pot. And it's a small specimen, that one. You can see it's just holding itself on the cup. So I'm just going to use a needle just to flick that into the specimen. And you can see there just sinking to the bottom of the pot. So we're going to take a few more of them. You okay? You're doing really well. What I was saying is, depending on the area that you are biopsying, patients can tolerate differently. So something on the larynx will certainly be more tricky than something tongue base or pharyngeal wall. There's another specimen, a good sized specimen there. We're going to try and take, if possible, 2 more. Is it very sore when it's taking just a little pinch that you feel? When you advance the specimen, you have to give it a little advancement push just to make sure you get good purchase on it. So again, another good specimen. Remember, the working channel is 2 mils, so anything that you use has to have a diameter of less than 1.8. But there are different instruments you can find. This is just the one that we use in our trust. So we're going again. And hopefully this will be the last sample, you'll be pleased to know. Another good sample there. So I've got enough samples. I'm happy with the sample size. I don't know if you can see them on the screen, but there's 4 large samples in there. Not too much, a little bit of bleeding. So we do routinely take some observations beforehand, just some simple blood pressure, respiratory rate, and we're going to sit the patient next door just to make sure there's no bleeding and making sure observations are stable. Obviously nothing to eat or drink for a good hour, and simple painkillers if needed.
And if a patient was on aspirin, would you stop the aspirin?
A few things to bear in mind, I suppose, if they're on anticoagulants, generally I would get to stop them, apart from aspirin. But it would also depend on where you're sampling from. So if you're sampling an airway that is slightly precarious and you're worried about bleeding, then maybe I would stop the aspirin. But something tongue base or pharyngeal wall, I would probably just, if they're on a low dose aspirin, I would carry on with the procedure.
Okay. And then finally, most important person is the patient. Valerie, how was that?
Alright, yeah.
What was the worst bit of it? Or
The 3rd biopsy. I think it's just a bit of a shock.
so
The first one?
The 3rd one.
The 3rd one, okay.
Yeah, I think it was
so they didn't feel the same then?
No, but that was a bit shock.
Okay.
Yeah, it just should be okay.
But your swallowing feels the same now as it did before, apart from the local, presumably.
Yeah.